Chairpersons, ladies and gentlemen, I take this occasion today to talk to you about closing the gap in cancer care in India. Now, in order to understand what the gap is, we have to understand the magnitude of the problem. The number of newly diagnosed cases annually in India is 17 lakhs 30,000. One in every 9 Indian male and one in every 7 Indian female is going to develop cancer in their lifetime. And unfortunately, 42.5% of males and 13.5% of females have tobacco-related cancers, which are totally preventable. Our annual cancer death is 8 lakh 80,000. And our mortality to incidence ratio is as high as 0.68, which fares very poorly when compared with very high human development index countries like USA and Canada and Norway, or even high HDI countries like China and Brazil. And then we have that north-south divide. The southern states have better resources and manpower because they had rapid growth under the stimulus package. They took advantage of the globalization post-1991, and they receive higher remittances from Gulf migrants and MRIs. So, patients from the poorer northern states usually travel to the southern states, which are better resourced and wealthier for treatment. India's national cancer grid is the bulwark of cancer treatment in our country. With its network of 183 cancer centers, research institutes, patient advocacy groups, charitable organizations, and professional societies, it treats only 7 lakh new cancer cases. And our incidence is 17.8 lakhs. So where are the remaining 10.8 lakhs? That is why this systemic failure to address the need of our patients contributes to 20% higher mortality among Indian cancer patients, even when we compare them to high human development index countries like China and Brazil. And this was a finding of a parliamentary standing committee on science, technology, and environment, which was headed by former Union Minister, Mr. Jairam Ramesh. Why do you think it is so? It is so because health in India is a personal problem and not a national problem. Our overall public expenditure on healthcare is still around 1%. Even till 2020, before COVID, we were spending 1.2% of our GDP on health. Compare this to US, it spends 17% of its GDP on health. Germany and Japan spends 10%. Italy spends 6.5%. UK spends 9%. And we are spending 1.2%. So if that is the expenditure on health, what would be the expenditure on cancer care? Below 10 US dollars per person is what India spends on cancer care. And more than 100 US dollars per person is what high HDI countries like China and Brazil spend on cancer care. That is the difference between us. So where is this money of cancer care coming from? From the pocket of the patient. It is this out-of-pocket expenditure which is killing him and his family. 60 million people slip below the poverty line every year. If you look at this chart, you will appreciate that public funds contribute to only 21%. And these are coming from central government, 8.34%, and state government, 12.2%. The remaining are all private funds. And of these private funds, only 1.13% comes from the insurance companies, and employers pay for their employees' treatment 5.73%. The remaining 71.13% is coming out of the patient's pocket. And it is negatively affecting not only the welfare of the patient, but his entire family. We need an urgent course change. Cancer needs to be seen and addressed as a public health issue. India's total GDP needs to be spent more ethically so that the general health of the population can be improved. Now, whatever out of pocket expenditure you are spending, do you know how you are spending this money? Please look at this pie chart. 52% of that money is being spent on medicines, 25% on the hospitals, 10% on investigations, 6% on transportation, 5% on paying the doctor's bill, and only 2% on cancer prevention. So that is why we need a change in attitude also, so that we spend more on prevention and less on medicine. Many patients have to travel long distances to be treated at a handful of major cancer centers, mainly located in the big cities. Now, this has three undesirable consequences. One, the patient spends a lot of money traveling and staying, and so has very little money left for treating. Secondly, patients and relatives stay away from work and lose earnings. And lastly, the major cancer centers are disproportionately overloaded. So there is delayed diagnosis and delayed treatment. The government is taking initiative. The Ministry of Railway is providing 100% travel concession to patients with cancer and 75% concession to family members. But will it not be better to have cancer centers in these poorer northern states so that the patient need not travel at all? Then I will introduce you this one particular word, inequity. In healthcare, inequality refers to uneven distribution of resources. Rich state, poor state, rich country, poor country. But inequity means unjust, avoidable difference in care and outcome. The equity gap is a reality not only in poorer countries, but in every country of the world. And I'll now give you a few examples. In the US, the 5-year survival rate of cancer cervix is 71% in white women and 58% in black women. In New Zealand, the Maoris are twice likely to die of cancer than non-Maori white New Zealand population. More than 90% of cervical cancer mortalities occur in low and middle income countries. Childhood cancer survival rates are as high as 80% in high income countries and below 20% in low income countries. The refugee population in our country is less likely to be diagnosed in an early stage, and they are invariably diagnosed when their cancer is advanced. Due to discrimination from healthcare workers and cancer screening programs, the transgender population in the West is far less screened than the normal population. There is a notable difference in cancer-related outcome for rural and urban patients. So how do we treat the problem of this gap? The most important tool we have in our disposal is education. 4 basic types of education programs are needed. 1, to increase public awareness of cancer. 2, for changing specific risk behaviors like stop smoking. 3, for learning self-examination skills like breast self-examination. And 4, for promoting early cancer detection in the community. We in India prefer personal contact to mass communication by radio and television. So we indulge in group discussions and chopals. We have telephone caller tunes like the one we had Amitabh Bachchan cautioning you about COVID. We can have home visits by ASHA workers and Ayush doctors, and we can have dialogue with doctors and social workers in primary health centers and tertiary care hospitals. Can it be taught in schools? Most certainly it can be. Oral hygiene should be taught and is taught in primary school. Sexual hygiene and risk of smoking and betel nut chewing should be taught to young adolescents. But the question is, how should it be taught? It should be in the form of interesting stories in vernacular language textbooks, basic Hindi reader, basic Urdu reader, and not in the form of sermons in English moral science or hygiene books. That will not work. Cancer education can be taught by giving some assignment at home, like making anti-smoking charts, because that will significantly improve the attitude of not only the students, but also the parents. The emphasis should be according to the age of the student, and the message should be sharp and crisp. Don't use tobacco. It will cause cancer. Eat healthy diet. Maintain healthy weight. Be physically active. Protect yourself from the sun. Get vaccinated. Avoid risky behavior. Get regular medical checkup. All this messaging has to be done interestingly through their textbooks. When resources are limited, we have to spend them ethically and logically. A few extra weeks of life in advanced cancer bought at disproportionate cost is not rational use of scarce resources. We must institute a system that deliberates and decides what constitutes cost-adjusted effective cancer care. The United Kingdom has such a system. It is called the National Institute of Health and Care Excellence Guidelines. The National Cancer Grid has initiated a process of creating evidence-based management guidelines, but the next step should be that they should have guidelines that can be used to make decisions to offer treatment either free of cost or at a subsidized rate, depending upon the economic condition of our patients. We need local cost-effective solutions to treat cancer. Development of rural comprehensive cancer centers is a very important step towards this process. The Tata Memorial Center has outreach programs in Ratnagiri and Sindhudurg. They are screening patients there, they are doing early detection, they are treating them there, and they are also offering palliative care. The Indian biomedical research should focus on search of innovative, cost-effective solutions that are not likely to come from rich countries. I'll give you two examples. One is breast self-examination. This should be taught to young girls in college. And the second is visual inspection with acetic acid or Lugol's iodine to screen for women's cervical cancer. Expecting subsidized funding for expensive anti-cancer drugs from the government is unrealistic. We have to repurpose existing inexpensive drugs. And we must develop low-cost radiation technology using cobalt-60 like Bhavatron or linear accelerator like Siddhartha, so that this can reach to each and every district of our country. There are many districts which do not have radiation facilities. Manpower, ladies and gentlemen, is invaluable. Shortfall in personnel and facilities in the public sector means long waiting list and spillage from the public sector to the costly private sector. The Government of India statistics are available only up to 2011. And even then, there was a shortfall of 12,000 specialists, general medical officers, radiographers, and community health centers related to cancer only. 5 states reported a shortfall of more than 1,000 personnel. Ladies and gentlemen, patient advocacy needs greater effort and coordination in India. Why I say so? A huge amount of money and the best talent in advertising is engaged in propagating a faulty lifestyle. The only pehchan kamyabi you can get by chewing pan masala is that you can get an oral cancer. But unfortunately, the advocacy to teach people how harmful pan masala is, that does not have any funding in India. That is the reason why we have to spend, we need good brand ambassadors, and we have to spend on advocacy in order to propagate a good lifestyle. Screening is valuable. Our cure rates are very poor because our disease is detected only at an advanced stage. Very little is being done for screening. We did a survey, a CPA survey of 150,000 healthy individuals, and the incidence of cancer was as high as 0.3% in healthy individuals. And when a subgroup was taken out, which had smokers and blood relatives of cancer, the incidence went up to 3%. So many lives can be saved through investment in screening, and that is the way ahead in cancer care. Relief of pain is an ethical imperative. Clinicians must maximize their knowledge and skill and diligence to attend to the task, and this can be done by drugs or patches or nerve blocks. A survey has indicated that 30 to 60% of cancer patients experience pain during active therapy and more than 70% during the advanced stage of the disease. Everybody who's had a cancer patient in their family knows that pain is an ethical imperative. We must treat it. Emphasis on quality of life issues is very important in the total management of cancer patients. Dentures for osteointegrated implants in free fibula for jaw reconstruction, limb salvage surgeries for bone and soft tissue malignancies, carbon fiber and myoelectric prosthesis for amputated limbs, and facial and orbital prosthesis will go a long way to address the quality of life in these patients. Not to forget, the mental quality of life too is important. So where there is progress, there is hope. When people unite, when communities rally around the vulnerable, when individuals innovate and collaborate across borders, when we win the fight in narrowing the gap between metrocentric cancer centers and rural outreach, and when we address the problems of inequality and equity, change will be within our reach. Thank you so much.